our next presenter is Dominique Simon-Levine, and she's going to present Allies in Recovery. Dominique.
Thank you. Hello, everyone. My name is Dominique Simon-Levine. I'm the founder and the CEO of Allies in Recovery. I believe we have built a system of care and support for the family of people struggling with addiction. And I believe we may have a new solution to a very, very big problem. 18 years ago, I took craft, an academic approach out of the University of New Mexico, and I created Allies in Recovery. I'm going to quickly tell you what craft is: community reinforcement and family training. It's the only approach that's been recognized by the Substance Abuse Mental Health Services Administration as an evidence-based approach. We teach craft to families unilaterally. We never see the person with addiction. We teach the family to be present in the moment. We teach them how to become influential and connected to their loved one with addiction. We teach families to stay safe, to understand the pattern and the cycle of use, daily use, weekly use, different drug use. We train families on how to communicate, how to connect, and how to listen, reflectively listen to their loved ones with addiction. We train families in a behavioral modification approach that looks both at the communication, the listening, and the reaction and response in terms of reinforcing positive behavior, non-using, and not reinforcing using behavior. So it's positive reinforcement in which you allow the natural consequences and the use when they are using, and you reward when they're not using. We teach this to families so that they do it in the day and in the moment. We teach families to care for themselves in a very deep way, to calm themselves so that they can communicate and listen in a better way. And finally, we teach them to engage their loved one into treatment. In 2015, I started this in 2003. In 2015, we went live online and we became a corporation as opposed to a not-for-profit. We took the 275-page physician therapeutic manual for master level clinicians and converted it into 52 brief video segments and 21 database exercises. Throughout these 18 years, Dr. David Scherer from the University of New Mexico has been very helpful in our content. I myself am a medical anthropologist, and for the last 25 years, I've been evaluating and researching substance use disorder programs, innovation programs, both for the states of Massachusetts, New York, and for the federal government. In our live program, we tailor answers to member questions as posts. We have over 600 answers at this point. We have a hugely popular podcast that we run weekly. And this past March, we added 16 hours of live virtual programming. We also train both families, paraprofessionals, and professionals on the use of our site and the use and the ability to give a warm handoff to a family to the site. I just want to give you some numbers. Our work is small in comparison to what I've been listening to, but I believe we have a fully formed product. These are outcomes of our member survey. I'm giving you just those families that responded that Allies in Recovery was extremely helpful. On the left, you see the family member and how helpful was Allies in reducing anxiety, worry, and anger. Close to 80% said extremely helpful. In the middle is the interaction between the two, because we're teaching families how to connect, to build the bridge, to partner, to be respectful, to show compassion, and to be useful in helping with resources and case management. And so that interaction between the two has to improve. And in the middle, you see how helpful Allies has been in improving how that family member talks to their loved one. 82% is said extremely helpful, and how that loved one responds to the family member. In this case, 56% of family members said their loved one was more responsive to them, extremely more responsive to them. And then finally, the loved one themselves, that's what we call people with addiction on our site. We guide the family, we teach the family on how to guide their loved one towards treatment. 38% of our membership said it was extremely helpful. The academic research shows that it's closer to 60% in studies. There are reasons why ours are lower, but 40% is a fine number. And finally, on reducing your loved one's drug and alcohol use, families worked unilaterally on our site with an e-learning program, reported that they were extremely helped in reducing drug and alcohol use, 33% of our families. So I just want to quickly tell you a little bit about the market and the context, except I can't see it. Okay. I believe it says up there that 92% of, sorry, I can't move this. All right. 12% of Americans have a substance use disorder. This is up from 10%. These are stats from the drug use survey out of SAMHSA that just came out. 94% of people with addiction do not get treated. And that again is up from 90%. Almost everyone who has a problem with addiction does not believe they have a problem with addiction. And those that do admit to a problem, 50% are resistant to treatment. The CRAFT work was designed by researchers at the University of New Mexico precisely to address this resistance. Can a family member motivate a person to get help? Can the family member decrease the problems of addiction? And the family members themselves, now we have a market that's practically half of the US. Among us today, many of you could tell me that you have somebody in your family that has a drug or alcohol problem. For family members, addiction is confusing. The families feel helpless. Helplessness is a big word in the work with families. There's tremendous suffering, but there's love, there's obligation towards that person. Family members, caretakers in general, but family members of those with addiction are the natural helpers. They're embedded in that immediate environment around that person, and they know that loved one best. Why did we do this at Allies in Recovery? The CRAFT model, which has something like 26 peer-reviewed articles, many clinical, top gold standard randomized clinical trials. It's very challenging to provide if you can imagine a family in crisis in front of you. It's a long certification process, about 8 to 12 months. CRAFT is not reimbursable by insurance in the United States because the family member is in front of the person, traditionally a master level clinician. They are not diagnosable unless you want to treat them for a depression or an anxiety, which is likely a family member will have with prolonged substance use in the family. This is also within a context of incredible danger, and families do this for years, and they need to be supported for years as they manage the situation and addiction in their family. So families end up as the de facto caregiver in a system that's highly fragmented, very hard to access treatment, and family members are not able to talk to the treatment. Oftentimes the treater just discharges the person and assumes they're coming back to the family. But there's been no communication between the treatment due to HIPAA and privacy, no communication between that treatment provider and the family. Traditionally, the system of CRAFT, done the traditional way with master level clinicians, 12 sessions, one family, cost about $2,500. We have several institutional members that have purchased our site. This is our 7th year. I'm just giving you one example, the state of Massachusetts. Right now, in 2022, it costs less than $15 to fully serve a family with CRAFT. And that cost is quickly going down to almost zero as scalability improves and as our marginal costs drop. We have served 450 people that year in Massachusetts. Allies in Recovery did the heavy lifting of the translational work of CRAFT. from this 275-page manual to 8 modules, 52 little segmented videos, and exercises, the whole e-learning program. The results you're seeing are from just that e-learning program and our exchanges with family members who write in with their specific situations. We apply craft and help them see next steps. At this point, our ability to scale is very good, and our cost to acquiring a new member or customer is very low. We are affordable to families. Families have often spent a great deal of money and time. They've been cheated and stolen from a lot of times, and they're not able to spend a lot of money. So we focused our business model on institutional sales, for which we have states like Massachusetts, counties like Palm Beach County, behavioral health hospitals, peer recovery organizations, which are cropping up all over the US. Our business to consumer pathway, we opened this last March, 2 Marches ago, sorry, in 2021, at trying to sell membership for $159 for 6 months through social media. And our return on investment is good at 140%.
Time check.
Thank you. Finally, we're trying to get to 3.0 with Allies in Recovery. We need capital investment. We have an AI partner in Achilles out of Portland, Oregon, Steve Dantana. We have a deep learning machine that accepts lexicon, natural language, and will accept write-only information data from the family. It's an interesting, innovative approach to patient monitoring. And we hope that we're going to be able to predict risk in little time, risk for both overdose, for relapse, and risk to the family of the stress-related conditions that they struggle with, and also the needs that they have in order to better protect their loved one. We have our 7-year e-learning program, which has served us really well. There are lots of bells and whistles we'd like to add: gamification, achievement, complete modules, rewarding that, and animation in which you may know the exact product, but it's that you're able to synchronize the mouth of the animation to dozens and dozens of languages. So we'd like to create the next version of our e-learning that could go out to over 70, 80 languages. Finally, what you see here is our young production team. I've worked 25 years, a lot of it in the Puerto Rican community. We created these familia novellas as a way to demonstrate, to feature a family that's been going through addiction, what happened, and then the local community leaders, in this case, the 3 here from the north end of Springfield, Massachusetts, talk about the story, the case that we've filmed and presented, and we've infused it with craft principles. So we're poised for rapid expansion with a very low marginal cost for acquiring a new member. I believe what we've done here holds the promise of a big solution to a very big problem. Thank you.
Thank you, Dominique. Questions from the judges?
If I can jump in, thank you so much for that. And also thank you for this mission of yours. Obviously with like the opioid epidemic, we need as a society to find a way to treat all kinds of addiction, right? One question I have is, can you comment on the use of psychedelics like mushrooms or psilocybin in treating alcohol? Recently, there's been some alcohol addiction. There have been some interesting studies released that indicate that that substance might actually help someone get over a different substance. And I'm just curious, as an expert in this general field, what your thoughts are.
It's very exciting. The psychedelics are treating in a novel way. The glutamate system, some address serotonin, but I'm seeing the same things you are. Very exciting. One study, 88% achieve abstinence versus 50% for those who are on placebos. It's very hard to study this because you don't get high if you're on a placebo. So they have trouble sort of keeping it blind. But yes, Absolutely, it's everywhere, and it's cropping up in many small clinics that you're able to try ketamine, for instance. MDMA is coming on board early this year.
Thank you very much for that.
Can you comment on the success rate of your version of the program versus the traditional version, and the sort of completion rate versus the traditional version? Are they more likely to complete your version, less likely? Is it equally successful, more successful?
The way the modules work, you don't have to complete all 8. You go to where you need, if you need communication, if you need behavioral work, if you need engagement into treatment, and then we support all of that with what we call human touch. And so what we have are outcomes of people that have used a little or a lot. We don't, we track. We can track their navigation and their journey through our site. I do know that in the studies, there was a good number, I'd say about 30% drop out within the first 12 weeks. But of those that complete, the outcomes are very similar to ours. In the studies, of course, they had treatment available across the hall for the family. So if you were able to engage your loved one into treatment at the University of New Mexico, you just got free therapy across the hall for them. So it was really easy to access and engage services, which it is absolutely not now in the US. It's very difficult. And families are left trying to figure it out very last minute in crisis often. So we work hard to help them build their lists of options right at the start when they join us. We have, my hope is to build community from this, and we have the credibility and the reputation now of being serious. In addictions work, you have scam, you have people not, promising cures and all the rest of it. It takes a while for us to have become sort of the place to go to, and that is occurring now. We have no competition. You have Al-Anon in AA, which is, very similar 12 steps, but for the family. But there is nothing, there's nothing as structured and as successful as what we've created.
I have a quick question for you. Given that this is really kind of created for the family support of these patients or these folks, have you considered partnering with any of the rehab centers to make it available to those families? Okay, because it sounds like you've got a couple of different ways that your business model is working.
Yes, we just yesterday, I spoke to a national treatment program that's out of Florida. They're all over about 8 states. Most treatment programs have very little family work. And if they do have family work, it tends to be, let's tell you how to get your loved one to the next place. But it doesn't involve the work of changing your own behavior, your own reactions, your own feelings about the situation, and to calm things down sufficient to be regularly support and to be seen as somebody safe to talk to, safe that you've built a bridge to, and that you can turn to. I do it in my family, and I'm like the interventionist, because I have 10 nieces and nephews, and I get the call, and they call me and they go, I got to get off the Klonopin, and I'm really scared, and they talk to me because of the way I talk to them.
Yeah. That makes sense.
Different. It's a completely different experience for both the family and the person with addiction.
Great, thank you.
Thank you.
Thank you, Dominique. This is a very up-to-date discussion. It happens every day in the hospital, and most of the time, all we can do is just give them resources. So, I can give them the name of your company, Alice in Recovery, but they have to initiate. They have to be willing to do it. And sometimes they call the family when they're in trouble, but then the moment when they wake up and they feel better, they just disappear, sign against medical advice, and they say, yeah, I'll deal with it.
It's very confounding for families, and to know how to navigate your way through that, and what's important, teaching them how to make those observations so that they understand the cycle of just the addiction that's going on, so they can focus on that and not everything else. it's a very effective approach, but it's hard for the family to work with it.
And I can't tell you how many times the family beg us to do something to hold them against their will, and we can't really do that. So it's complicated, but I think there's a market there. Definitely the families are willing to do everything possible. And I know people that have gone to a couple of rehabs before they actually become serious about really trying. So
Yeah.
thank you.
Caretakers are the future, and they are going to be the home treaters, and they are going to be the initiators, and they are going to be given some power, like with our AI, to be able to write only into the machine, to be able to pull our aggregate information so that we can really start to design prescriptions and meet the needs much quicker and prior to the crisis.
Thank you very much.
Thank you.
Thank you.